Now it's time to introduce our speakers for today's talk, Dr. Chris Bryant and Dr. Michael Sweeney. Dr. Bryant is a professor of pediatrics in the Division of Pediatric Infectious Diseases at the University of Louisville School of Medicine and director of the Pediatric Infectious Diseases Fellowship Program. She serves as the hospital epidemiologist at Norton Children's Hospital and is part of the leadership team for infection prevention at Norton Healthcare. Dr. Bryant is also active in statewide efforts to prevent healthcare-acquired infections and is a member of the Kentucky State Regional Infection Prevention and Epidemiology Committee. Dr. Michael Sweeney is an assistant professor in child neurology at the University of Louisville, where he has been since 2016. He completed his medical education at the Medical College of Wisconsin and his residency at Cincinnati Children's Hospital. He then went on to become the first pediatric neurologist to complete an autoimmune neurology fellowship at the University of Utah as a James T. Lubin Fellow through the Transverse Myelitis Association. Dr. Sweeney pioneered the region's first clinic for children with immune-mediated neurological disorders and co-founded an adult autoimmune neurology clinic. So thank you everyone for joining us. They are going to talk about a look back at the 2024-2025 flu seasons and lessons for next year and beyond. So I'll turn it over to you all.
Thanks so much, Dr. McDonald, and thanks to the audience for joining today for an interim look at the 24-25 flu season. Spoiler alert, it's not yet over, but we have some interesting updates to share, and I think it's worth an interim analysis. It's not too early to plan for next year. So let's get started. Our objectives today are really to look at the epidemiologic trends of the current flu season. We're going to talk about an unusual neurologic complication called influenza-associated necrotizing encephalitis. And we're very fortunate to have Dr. Sweeney here to talk to us about that. We'll talk a little bit about the current influenza vaccination strategies. We'll provide evidence-based recommendations for improving flu prevention in pediatric care. And we'll talk just a little bit about avian influenza, which is an emerging pathogen in humans. So let's get started. In some respects, this is a talk full of news bites. Some of you may have seen the headlines. This is the worst flu season in 15 years, and it's certainly been a challenging one. Let's look at the numbers. So preliminary estimates. Just through the beginning of March, there have been at least 41 million illnesses, more than 19 million medical visits for flu. I'm sure many of you felt that in your offices. There have been at least 540,000 and maybe more than 1 million flu hospitalizations. I'll show you some data in children. And across all age groups across the US, more than 23,000 deaths, but potentially much more, according to CDC estimates. So let's look at some of the data that goes into determining if a flu season is severe. This flu season is categorized by the CDC as severe across all age groups, and it's the first time we've had a severe flu season in all age groups since the 2017-2018 season. The data on this slide are from the National Syndromic Surveillance System, and you can see the high proportion of ED visits this year with a discharge diagnosis of flu. Last year was pretty bad, as you see on the left-hand side of the screen, but this season was even worse, and at the height of the flu season, 17.7% of ED visits in kids 0 to 4 years of age had a discharge diagnosis of influenza. Well, what about hospitalizations? We know from the CDC surveillance platform, fluserve.net, that influenza hospitalizations have been increased this year in kids less than 18 years of age. Depicted on this slide are laboratory confirmed um, laboratory confirmed influenza hospitalizations in kids for 10 seasons. I just want you to focus on the red line. That's this season. And you can see that this has the highest number of influenza hospitalizations in about the last 10 years. I think it's also sobering to recognize that approximately half of influenza hospitalizations have been in kids that have no known underlying condition. These are otherwise healthy kids that have been admitted to the hospital with flu. The most common underlying condition is asthma, followed by underlying neurologic disease, and then obesity. We know that every year kids die of influenza. Some of these kids are previously healthy, and most of them are unimmunized. On the right-hand side of the slide, you see national data from the CDC. This is still an evolving story because the flu season isn't over. But to date, 134 kids in the United States have died from the flu, and three of those kids have been in Kentucky. On the left-hand side of the slide, you see Dr. Stack announcing the first pediatric flu death in Kentucky. Now we are up to three, and one of those children was from Jefferson County. Louisville Department of Public Health and Wellness has a new flu dashboard this year. So if you really want to know what's happening in Jefferson County, I've given you the link. Again, this is updated weekly. So far this year, we've had more than 18,000 cases of flu reported to the health department. Now, these are people who had a test. We know that not everybody with flu gets tested, so this is an underestimate. In people of all ages, we've had 20 influenza-related deaths. One of those, again, was in a child. I think the most dramatic statistic is the number of outbreaks. These occurred not just in medical facilities like long-term care facilities, but schools and child cares. And again, let's go back to the news headlines. A number of Kentucky school districts closed or moved to non-traditional education because so many kids were out with the flu, so many teachers were out with the flu. Flu season was really disruptive to education this year. Now, we tend to think of flu as a respiratory disease, and of course it is, but it's not just a respiratory disease. Flu can affect a number of organ systems. We know that there are cardiac complications like myocarditis and pericarditis. There are musculoskeletal complications like myositis. Today, particularly, we're going to talk about neurologic complications of influenza, and we are very fortunate to have Dr. Michael Sweeney here to help us with that. So, Dr. Sweeney, I think some people in our audience may have seen this article that was published in the Journal of Pediatrics several years ago. This was a cross-sectional study involving kids 2 months to 17 years of age who were hospitalized with influenza. 49 children's hospitals contributed data. And what was reported was that almost 8% of kids hospitalized with influenza had a neurologic complication. And of those, the most common complication was febrile seizure. How does this relate to your experience at Norton Children's?
Yeah, I think this kind of nicely mirrors what we see in the hospital in real time. I think the most common thing that we tend to see are kids who have underlying neurologic disorders like epilepsy or migraines. They tend to have more of those exacerbations of those underlying illnesses when they have the flu. Now we definitely see kids present with new febrile seizures in the setting of flu. Those are in our age groups, those 6 months to 6 years, but classically are 18-month-old. Um, we we've seen encephalopathy, which really is kind of a broad definition, but kids who are otherwise well, but they develop fatigue or sleepiness, all the way up to kind of really sedated appearance. They're very altered and not responsive to external stimuli. Um, so those are the things we tend to see. There are definitely some rare kind of zebras that they include in this list that we don't tend to see commonly, even when our flu cases are much higher, luckily. But yeah, those I think that does mirror kind of the extent of things that we see with flu.
Yeah, thanks for sharing your experience and pointing out that neurologic complications were more common in this study and in your experience in kids with underlying illness. So, flu can exacerbate underlying disease. Now, this same group of investigators ask a slightly different question. They use the Tennessee Medicaid database to try to answer the question of all of the kids who get diagnosed with flu, not just kids who are hospitalized. How many kids have a neurologic complication? And so, in this cohort of more than 156,000 kids who had a diagnosis of flu and who were followed by Tennessee Medicaid, the answer is neurologic complications are not so common. They occur at a rate of about 30 per 100,000 person weeks. But again, they're more common in kids with an underlying neurologic comorbidity. And the most common complication um, was seizures. Um, Dr. Sweeney, how does this strike you?
I don't know that this data is always kind of hard to interpret because it really depends on the ICD-10 codes that are used in these cases. So to see that seizures are more represented than headaches is a little bit, non-believable to me. It seems like it's probably that the people who were suffering with headaches were suffering at home and maybe didn't seek care. But for the people who sought care, yeah, certainly you're going to seek care if you have seizures, and that's going to pop up higher on our incidence in this kind of study. Um, Again, I do think this captures the spectrum of different syndromes that we see with flu as it pertains to the nervous system. Um, yeah.
All right, thank you. And so before we leave this slide, I want to point out this little box, encephalitis. Encephalitis is a known, but fortunately rare complication of influenza. But it's more common this year for reasons that I don't think we understand. So earlier this year, neurologists at multiple children's hospitals reported seeing an increase in this rare complication. And that led to public health alerts, like you see on the right from the LA County Health Department, asking for clinicians to report cases of influenza-associated encephalopathy and encephalitis and acute necrotizing encephalopathy. So Dr. Sweeney, why don't, if you will, explain to us these terms?
Yeah.
What really is this influenza-associated encephalitis or encephalopathy?
So this term kind of captures a spectrum of disorders, maybe that we kind of put under an umbrella, which suggests that symptoms that kids present with are caused by influenza, but not necessarily directly. So we tend to think of this disorder as a post-infectious or peri-infectious syndrome where the body's response to the influenza virus becomes dysregulated or kind of amplified, and then that inflammation or dysregulated immune response is what triggers off our neurologic symptoms. Now, that's not to say that we can't get direct invasion of the nervous system with influenza, but we tend to think of this spectrum of disease as probably a more of a post-infectious process. And it really varies in severity. So we have kids who have very mild symptoms. They might have one seizure or may have more of a delirium where they're just kind of fussy and not as responsive or quick to answer as would be typical, all the way up until kind of a full psychosis or a comatose child who's minimally responsive. And then at the very top end of the spectrum, we have a more, the most severe form of this umbrella, which we term acute necrotizing encephalopathy or encephalitis. This term we use really, so you kind of meet the criteria for an influenza-associated encephalopathy, but we have these really dramatic, severe changes on brain imaging. So you can see in this slide on this T2 weighted MRI of the brain, you can see in the deep structures of the brain and the thalami, we get this kind of symmetric, really swollen appearance, bright T2 signal. And these kids are very sick. They're very encephalopathic. These are kids in the ICU. And they typically present with altered mental status that begins between 1 and 3 days after the onset of their febrile illness. Their spinal fluid is typically fairly bland, so we don't tend to see a lot of white blood cells. We may see an elevated protein level. We may see an elevated opening pressure, but otherwise not as impressive as what the imaging and their clinical appearance looks like. Interestingly, there's a number of kids who kind of meet this criteria who do have a genetic mutation, which we think increases their risk for developing this type of picture. And that's in the RANBP2 gene, which is kind of a poorly understood gene, but we know it has roles in cell signaling, and mutations in that gene result in interrupted cell signaling with nuclear signaling with this really big cytokine release syndrome that happens in viral infections. So there's historically cases of acute necrotizing encephalopathy that we thought were triggered by flu. We find this mutation. Now, all kids that present with this don't get tested, don't get genetic testing. And so we don't know really the percentage of kids with ANE that have this particular gene, but there's probably some underlying genetic predisposition to developing this severe end of the spectrum of kind of post-influenza encephalitis. This year, we did see, I think, more kids present in our hospital with flu-related encephalopathy, but they tended to be on the more mild end of the spectrum. So these were kids who they may or may not have a pre-existing neurologic condition, but they developed, changes in their mental status that lasted for a bit longer than we usually see with flu. And I think the severity of symptoms is kind of what prompted people to start getting concerned, and prompted the different agencies to start trying to collect some case data to see, what the signal was going to be there. I can think of a number of cases that we saw here locally. There were children with some mild neurologic symptoms that had presented in the past who came in with flu, and they were altered for several days. They ended up getting a big workup and we didn't find much and we just did supportive cares for them and they got better. We didn't see any cases that I'm aware of, and I kind of crowdsourced a bit. My partners, I'm not aware of any A&E cases that we saw this influenza season, though we have seen some in the recent past. And we've had a couple of post-flu ataxia presentations where kids presented with kind of acute cerebellar ataxia type of picture, which is typically in our like toddler school age range kids. And but those were pretty mild. And then we've had one case of post-influenza Guillain-Barré syndrome.
Mm. Wow. Quite a year. I appreciate that you highlighted the spectrum of disease associated with influenza-associated encephalopathy or encephalitis can be mild, and kids recover fully, or it can be associated with severe or even fatal disease. The anecdotal reports coming from neurologists at a number of centers across the country prompted the CDC not only to say, tell us about any cases that you're seeing, but also to look back at pediatric influenza deaths, 2010 through the present, to look and see how many of the kids who died had deaths associated with an IAE diagnosis. And on average, it was 9%, although the range was from 0 to 14% a year. And I think the highest number of cases was in kids 2 to 4. We know that kids under 5 years of age are at higher risk for complications from flu. So, Dr. Sweeney, any advice for parents who are worried about this complication of flu?
Yeah, I mean, I would keep in mind that this is a rare complication, but certainly when your child is having symptoms that are not in line with what we would typically expect for flu. So if your child is hallucinating or they're not as responsive as they should be, if they're not able to maintain their hydration, those are the kids that we expect to see in the hospital, to watch them closely and provide the support they need to get over these things. Um, I think, but I think the overall arching message should be that these are super rare presentations, although albeit they're scary to hear about. Um, Interestingly, I think the 2020 year was a very mild year, and now we're kind of shell shocked with the rises in cases since then.
Yeah, definitely. I think, during the early years of the pandemic, when everybody was staying at home and wearing masks and isolating, we didn't have circulation of run of the of routine respiratory viruses. And I think some people, some parents forgot or just didn't know that flu could be a severe illness in kids, that it was more than just a cold. Why don't we stop there and pause and see if there are any questions specifically that the audience wants to ask Dr. Sweeney? Dr. McDonald, do we have anything in the chat?
We do not.
All right. Dr. Sweeney, thanks so much for joining today and providing your perspective on neurologic complications associated with influenza.
My pleasure.
All right, so this is a little bit of a rhetorical question as we move on. Why has this been such a bad flu season? Well, some years we have a mismatch between circulating viruses and the flu vaccine. The CDC has published an interim analysis of the effectiveness of flu vaccine, and preliminary analysis is that it worked pretty well. It in three different CDC networks, flu vaccine effectiveness was assessed in ambulatory kids. And so, in terms of preventing medically attended influenza, vaccine effectiveness ranged from 32% in the US flu vaccine effectiveness network. It was higher in the NVSN network, 59%, and 60% in the Vision network. Now, if you drill down on these numbers a little bit, you can see that effectiveness was higher in against influenza A H1N1 compared to influenza A H3N2. And this was consistent across the two networks that looked at subtyping. Now, interestingly, this year, both H1N1 and H3N2, those kinds of influenza A, were circulating at the same time, which is it happens, but it's a little bit unusual. The vaccine did have benefit in preventing influenza-associated hospitalizations. Two networks looked at hospitalizations. The New Vaccine Surveillance Network, or NVSN, vaccine effectiveness was 63%. You can see the confidence intervals are a bit tighter than with medically attended outpatient visits. We know that the biggest benefit of flu vaccine is preventing severe illness. And I think that was borne out in this year's interim analysis. In the like the outpatient data, the vaccine was appeared to be more effective against H1N1 compared to H3N2. We just haven't seen a lot of B circulating to know as much about effectiveness against B. Effectiveness was even higher in the Vision network at 78%. So probably not a vaccine mismatch. I think the bigger problem is that kids just aren't getting flu vaccine. Influenza immunization rates in kids 6 months to 17 years of age fell again this year. Look at the coral line at the bottom. Less than half of kids nationally are protected against flu. And you know, every year there are disparities. Historically, there have been racial disparities in who ends up being protected against flu, with lowest rates among Black kids compared to white kids and Hispanic kids and kids of other races. This year, the CDC posted vaccination rates by poverty status. And there is some, I think, important variability to call out. So if we look at kids who live in a family with an income above the poverty level, but less than 75,000, only 39% were vaccinated against flu this year. What about Kentucky? Those are national data. But what's happening right here in our state? Well, in our county, in fact. Kentucky Department for Public Health has an influenza seasonal dashboard where you can look at immunization rates. The first thing I want you to see is that immunization rates vary by county. It's not the same. And in fact, appeared lower in rural parts of the state. I can tell you that in Jefferson County, our influenza immunization rate in children was about 30%. All right, so how are we going to make the next flu season better? Um, when we talked in the fall, and I talked to you about getting ready for the influenza season, I talked about vaccine communication and the importance of the presumptive recommendation. Mrs. Jones, your child Sarah is due for her flu vaccine today. We have it ready to give to her. I'm not going to talk about vaccine communication again during this session. I really want to talk to you about improving immunization rates by increasing access to vaccine. The strategies on this slide are part of the American Academy of Pediatrics annual influenza policy statement and are probably familiar to many of you. The AAP recommends assessing influenza vaccination status at every visit during influenza season. Bundle influenza vaccine with any other needed vaccines. It can be given at the same time as other vaccines. Vaccinate at all visit types, including sick visits, as long as a child is not moderately or severely ill. If they're in for an otitis and not very sick, give them a flu vaccine. If they're in for a minor injury, give them a flu vaccine. Vaccinate in all healthcare settings, including the emergency department. Dr. Becca Hart at Norton Children's has done some really innovative work showing that the emergency department is an effective and appropriate place to deliver flu vaccine. The AAP encourages providers, as if feasible, to have expanded hours, consider vaccine-only clinics. The AAP really emphasizes that the best place for flu vaccine and for all vaccines is in the medical home when it's feasible. But in order to increase influenza immunization rates, we need to think about partnering with stakeholders to support vaccine initiatives within the community. And this includes school-based immunization programs and partnering with pharmacies. Next year, there will be a new way to increase access. Last year, the FDA approved administration of the nasal spray influenza vaccine or live attenuated influenza vaccine, LAIV, at home. And so adults can give it to themselves, and to eligible children as young as 2, it can be administered as a caregiver in the home. Although it was approved last year, at-home administration of LAIV was not available this year, but it will be available next year. No prescription is required for this. A caregiver or parent will be able to go online, fill out a questionnaire to determine if their child or themselves are eligible for LAIV. If they are available, the dose is shipped to the home. There's special packaging that will maintain temperature control of the vaccine. After the parent or caregiver receives the vaccine, they will have to attest that the vaccine has been administered. I'm told that they will receive a text asking if they've administered the vaccine, or they can go onto an online portal. And then a central pharmacy or partner organization will upload vaccine receipt, or that the parent has attested to vaccine receipt, into the immunization registry. So stay tuned. The AAP again emphasizes immunization in the medical home, but we know that especially older kids are getting their flu vaccine in pharmacies. And this may be a way to increase access to vaccine and increase immunization rates. I want to share with you a really interesting paper that was recently published in the Journal of Infection. Um, and this was a modeling study that posed the question, all right, what might even modest increases in influenza immunization rates do to the number of cases of flu, as well as hospitalizations for flu? So the assumptions that went into this model were the vaccine is 40% effective. That sort of tracks with what we saw for effectiveness of this year's vaccine. And what if we just look at school-age children? What if we could just increase immunization rates by 5%? If you look on the left-hand side of the slide, you can see the estimated number of symptomatic cases of flu prevented in 15 to 17-year-olds. That's where we're increasing immunization rates. But we would also prevent more symptomatic cases of flu in other age groups as well. The shaded bars indicate what would happen if the flu vaccine wasn't 40% effective, if it was 45% effective. Um, and the gray bars are a 5% increase in immunization rates. The blue bars are a 10% increase in immunization rates, and the red bars are a 15% increase in immunization rates. Again, just in school-age children. Now, if you take a peek at the right-hand side of the slide, you can see that increasing immunization rates in school-age children, according to this model, would decrease hospitalizations not only in school-age children, but in other age groups as well, particularly in people 65 and older. And that's because immunizing school children can decrease the transmission of influenza in the community. So this is an intriguing model. Now I want to shift gears away from seasonal influenza a little bit and present to you a clinical challenge. What do you think about this case? A 13-year-old girl presents to an emergency department with a 2-day history of conjunctivitis and a 1-day history of fever. She's not very sick and she's discharged home. But over the next 3-ish days, cough, vomiting, and diarrhea develop, and she presents back to the hospital with respiratory distress. She ultimately requires mechanical ventilation and ECMO support. On the day she's admitted to the hospital, a respiratory PCR panel is positive for influenza A, but the specimen doesn't type as H1N1 or H3N2, seasonal influenza strains, but it's an influenza A. And so the question arose, could she have avian influenza or bird flu? So what is avian influenza or bird flu? I'll share by saying there are multiple kinds of avian influenza, but the avian influenza strain of highest concern right now is avian influenza H5N1. This is a type of influenza A virus that primarily affects birds. We say H5N1 is highly pathogenic because it's highly pathogenic in birds. It kills birds. It's highly contagious among birds. And again, can lead to severe illness and death. But it doesn't just affect birds. Over the last several years, H5N1 strain of influenza has been increasingly detected in a variety of mammals, including dairy, cattle, and domestic cats. This virus is spread through direct contact with infected animals, their feces, their saliva, their mucus. In the case of dairy cattle, their milk, or any surface that's come into contact with an infectious fluid. Humans can rarely become infected through close contact with animals or their environment. And again, while this is highly pathogenic in birds, the spectrum of clinical illness in people is much broader. And some people have had mild flu-like illness, conjunctivitis, fever, cough. Some people have only had conjunctivitis. Some people have had very few symptoms at all. But severe cases have been reported in the US, including difficulty breathing, pneumonia, and death. There has been one fatal case of avian influenza H5N1 in a human, in an adult in the US within the last year. There has been no human to human transmission, though. And that's the good news, at least for now. So, situation update from the United States. There have been 70 cases of avian influenza H5N1 in humans so far. A few of these cases have occurred in children. The majority of them have occurred in adults with occupational exposures. On the left-hand side of the slide, you can get a sense of the burden of disease in animals. 41 outbreaks in dairy cattle herds. There have been multiple outbreaks on poultry farms. There have also been other animals. We'll talk more about that. And in a few people, who of these 70 who have been infected, no exposure source can be identified. So they haven't been infected they don't have exposure to dairy cattle, they don't have exposure to poultry, either commercial operations or backyard flocks. We just don't know how they got infected. The current situation in Kentucky is that there have been no human cases, but we have had cases of avian influenza in birds, including birds in Jefferson County, as you see on the slide. These are all wild birds, no detections in poultry or dairy cattle. This state is participating in an initiative to test milk, and no samples of raw milk have tested positive in Kentucky. I mentioned that a variety of mammals can be infected. The state is actively testing cats that are submitted for rabies testing. None of these cats have tested positive for avian influenza, and again, no human cases. So let's go back to our clinical challenge. Our 13-year-old in the ICU was infected with avian influenza H5N1. She had a prolonged hospital stay, but she ultimately recovered. This case was a girl in Canada. This case was published in the New England Journal of Medicine, and preliminary reports are that she had no known risk factors for avian influenza, but the influenza sample that was recovered from her was very similar to a sample that was recovered from infected wild geese in Canada. So if she had no risk factors, what are those risk factors? If we had a child admitted to Norton Children's who was sick and in the ICU and had an avian influenza that didn't type, that was an influenza, or I'm sorry, that had an influenza A that didn't type as a seasonal flu, H3 or H1, what would we do? We would send the sample to the state for further testing, and we would ask risk factor questions. Have you been exposed to any animals or people with confirmed avian flu? We'd ask about people, even though there's no human to human transmission documented yet. We'd ask about close contact with wild birds or chickens. There have been avian influenza transmissions to people from backyard chicken flocks. We'd ask about close contact with dairy cattle or consumption of raw milk or dairy products. We might also ask about exposure to sick cats. So, what's the deal with avian flu in cats? More than 80 domestic cats have been infected with avian influenza since 2022. Symptoms of avian flu in cats include runny nose, eye discharge, and interestingly, neurologic symptoms like dizziness and seizures. How do cats get infected? Veterinarians think there are a variety of ways, maybe from hunting and eating diseased wild birds, maybe from consumption of unpasteurized milk. There have been transmissions from raw pet food. And recently, in the CDC's Morbidity and Mortality Weekly report, infections were identified in a couple of cats who lived in the homes of dairy workers. And so the thought was perhaps the dairy workers brought home avian influenza on their clothes, and that was a potential mode of transmission to the cats. All right, so common sense strategies to protect against avian influenza. Avoid sick or dead birds. Avoid sick or dead animals, especially birds. If you see dead birds, you can report them to the state vet in Kentucky. I've included instructions below. Cook eggs, poultry, and beef to appropriate temperatures. Now, in the US, there have been no transmissions of avian influenza to people from undercooked eggs or undercooked poultry or beef. But we know that undercooking all of these things can lead to other illnesses. So CDC recommends cooking them to appropriate temperatures. Avoid raw dairy products because these can harbor influenza H5N1. And it seems like a good idea to protect your cat against infection. I'll stop there and see if there are any questions about influenza.
All right, Chris. I don't know if Michael had to see a patient, but if there some of these patients that are getting the neurological symptoms and the encephalopathies and et cetera, are they having higher fevers than the other normal flu patients?
I have not seen the data reported in that way. I think we'll have a much clearer picture once these cases, the active call for cases is completed and CDC has a chance to analyze the data. But I would say not necessarily. Not all of these cases are in kids who have the extremely high fevers.
Okay, and then the cancellation of the flu meeting for next season, that seems to have concerned some people. So are you worried that we will not have any flu vaccine at all for next season?
Yeah, it's a great question. The WHO has made recommendations for the composition of the influenza vaccine for the Northern Hemisphere. And I am told that vaccine manufacturers are going ahead with those recommendations. I think the H1N1 and influenza B strains will remain the same, but H3N2 will be changed. So the manufacturers are just going ahead, and I anticipate that we will have plenty of flu vaccine for next season.
Okay. And can you reiterate one thing about the vaccine being effective? Was it effective in preventing hospitalization or death or encephalitis, or is there any data on those things?
Um, yes. So every year, the CDC, and I'm just going to go backwards, close your eyes if this makes you dizzy. Um, every year, the CDC studies vaccine effectiveness. Um, and every year, it's a range for effectiveness, and it depends on how well the vaccine is matched to currently circulating strains. So, for medically attended influenza in outpatients, the vaccine effectiveness numbers are on this slide. And CDC has three different networks that look at influenza vaccine effectiveness in kids, and the numbers were different depending on the network. So, uh, in US flu, vaccine effectiveness was 32%, but with really wide confidence intervals. And you can see that for influenza A H3N2, it didn't seem to work very well at all. But that's one network. In the new vaccine surveillance network and in Vision, vaccine effectiveness was higher and did prevent medically attended influenza in outpatients. Now, effectiveness, and again, this is an interim analysis of this flu season. There'll be another analysis at the end of the season, I would think, but vaccine effectiveness was better. 63% in one network, 78% in another. Confidence intervals are wider. So we have that's more compelling data. And I will say this is pretty consistent from season to season, that influenza vaccination prevents severe influenza, prevents hospitalizations. There are data that it prevents ICU admissions and the need for mechanical ventilation. Um, I think what I will say about influenza associated encephalitis and encephalopathy, um, you're not going to get that if you don't get influenza. And so I don't think vaccine is 100% effective because there are cases that are reported of encephalitis and encephalopathy in kids who were immunized. Um, but there is benefit in not getting flu. And so um, this is one way to try to protect your kid from this serious complication of flu.
So this
Yes,
slide is preventing hospitalization, but
correct.
what does the previous slide mean preventing outpatient? Is that just getting the flu at all?
Getting the flu and needing to go to the doctor for it.
Just needing to go to the doctor. Okay.
Yeah,
Okay. And while we have you on the spot here today with the audience, can you touch on measles quickly?
I would love to. Um, so yeah, let's talk for just a minute about measles. Um, Clinical challenge, 11-month-old presents with uh, fever, cough, runny nose, red eyes, and a rash that begins at the top of the head and goes down the body. Um, I bet some of you are wondering about her travel history. Um, um, this child has actually traveled outside the US. Um, she did not get an MMR before she left. And you appropriately suspect measles. Um, I wanted to highlight her international travel history, but these days you don't need to travel outside the US to be exposed to measles. I made this slide several days ago. The total number of cases of measles in the US has continued to climb. There have been multiple outbreaks. The audience is likely aware of a large outbreak in Texas. And you can see that the majority of measles cases are in children and children who are unimmunized. So, if you saw the child that I presented, fever, cough, coryza, conjunctivitis, went to a place where she was likely exposed to measles and was not immunized, you would want to test for measles. Um, the only way to know for sure is to test because a number of other rash illnesses can look like measles. Um, and this includes infectious diseases and non-infectious diseases like drug eruption. Let's talk for just a quick minute about how we test for measles. The preferred test is a PCR test of the nasopharynx or the throat. I have urine on this slide. The Red Book mentions urine. The Kentucky Department for Public Health actually just recommends the respiratory specimen. The state lab is running measles test on kids who have a high clinical suspicion for measles, and they are able to get the test back to us pretty quickly, much more quickly than a reference lab. If you work in the Norton healthcare system and you see a child that you suspect has measles, call the infection preventionist that is partnered with your area, and they can help you make contact with the health department to get permission to send a PCR test. There is permission required to send a test to a state lab, but again, we're getting the test back super quickly. We want to get the test back really quickly in case we need to give post-exposure family, the school, the daycare. So we don't want to wait for that test to go to a reference lab. We had a kid who came to the hospital recently with suspicion for measles, and a PCR wasn't ordered, only serology was ordered. IgM can be sent as an adjunctive test. Getting a positive IgM is supportive, but not diagnostic. There are false positive IgM tests. You can see a false positive with parvovirus infection, mono, and some rheumatologic diseases. So the PCR test is really the most important. IgG is less important in confirming acute infection, but can be done to confirm prior immunity. In terms of this has been in the news a lot. What about vitamin A? Is this a treatment for measles? There's no antiviral that can treat measles. Both the AAP, the CDC, and the WHO recommend that vitamin A be used to treat severe cases of measles in children. But this is not a preventive strategy. Vitamin A is no substitute for measles, mumps, rubella vaccine. It's only given after a child has measles to try to lessen the severity of disease. In low and middle income countries, where children are more likely to be IgA deficient, this has been found to lessen the severity of disease. We probably have less IgA deficiency in the US, but this is recommended for severe cases. Under the supervision of a medical professional, there are, of course, risks of toxicity from too much vitamin A. I think we are probably out of time, but I'll just leave you with this slide that vaccination is the very best prevention for measles. All children need 2 doses of MMR vaccine, and kids traveling internationally who are 6 to 11 months should receive a dose of MMR before they go, followed by 2 doses at the recommended ages. Dr. McDonald, I'll stop there.
All right, quick question. Should we be vaccinating earlier for the second MMR rather than waiting until age 4? And what if they are traveling within the US, like a Disney vacation, or with a medically complex child?
Yeah, so in terms of vaccinating early, not routinely necessary. And unless you're going to a place where measles is spreading. So are you going outside the country, anywhere outside the country? You want to get that child there, that would be a reason to give the vaccine early. What if you're going to Texas? Well, if you're going to a place where measles is spreading, um, then you could consider vaccinating early. But you don't need to, we don't need to routinely recall in and give them their vaccine early. Um, Dr. McDonald, I think there was also a question about a booster vaccine. And so adults who've had all of their recommended doses of vaccine don't need a booster. For healthcare workers, we should have 2 vaccines if you have documentation of that. You do not need a booster. Did I get the questions?
Yep. All right.
All
Thank you.
right.
All
Um,
right. Thanks everyone for joining us today.